In this presentation, we share our study on deep learning-based automated detection and burden assessment of paramagnetic rim lesions on quantitative susceptibility mapping in patients with multiple sclerosis. Multiple sclerosis is a chronic immune-mediated disorder of the central nervous system that drives demyelination, axonal damage, and progressive neurodegeneration. Among its pathological hallmarks are chronic active lesions, sometimes called smoldering lesions, which are markers of persistent inflammation. These lesions are characterized by iron-rich, chronically activated microglia and macrophages at their margins, and that iron signature is exactly what makes them visible on susceptibility-weighted MRI, including SWI and QSM. On imaging, these chronic active lesions appear as paramagnetic rim lesions, or PRLs. A PRL is defined by hypointense rim on susceptibility MRI, corresponding to iron-laden microglia and macrophages at the lesion edge. PRLs have become an established radiological biomarker of chronic active inflammation and ongoing tissue injury. QSM is particularly useful here because it provides a quantitative measure of tissue magnetic properties and enhances our ability to detect these rims. The problem is that identifying PRLs still relies largely on expert visual review, which is slow, variable between raters, and impractical at scale. So our goals were threefold. First, to train and validate a deep learning framework for automated burden assessment using QSM with whole volume input. Second, to compare a QSM-only configuration against the combined QSM plus FLAIR configuration. And third, to evaluate the clinical relevance of the automated burden our model produces. This was a retrospective analysis at a single tertiary academic MS center. From our screen population, we defined an exploration set of 84 patients, split into training set of 54 and an internal test set of 30. The split was done using a predefined non-randomized procedure that ranked patients by lesion count and volume so that per burden was balanced across sets. We also held out a temporal test set and a separate clinical implication cohort to examine associations with patient outcomes. This flowchart summarizes how patients moved from initial screening through our eligibility criteria into the exploration, test, and clinical cohorts. All imaging was acquired on 3 Tesla MRI with 64-channel head coil. Using 3D gradient recall echo approach, we obtained pre- and post-contrast 3D T1 weighted images, 2D T2 turbulent speed echo, and 3D flare and multi-echo susceptibility weighted sequences with 7 echoes. QSM was then generated automatically from the multi-echo GRE data using the total generalized variation, or TGV algorithm. To build our grand truth, a radiologist with 13 years of experience and a neurologist with 18 years of experience independently reviewed the images while blinded to clinical information. They then performed a side-by-side consensus annotation of pairs on QSM using 3D slicer, and the merged masks became our consensus ground truth labels following the recent consensus statement. Lesions smaller than 10 voxels were excluded to ensure reliable characterization. For pre-processing, brain extraction was performed with free surface synth strip. Registration used 2-step strategy. A flare was first resampled to QSM dimensions and then registered to the skull stripped magnitude image using FSL's flirt with 12 degrees of freedom. The resulting transformation was applied to align flare with the QSM coordinate space. Our exploration set comprised 84 patients, 69 per positive, contributing 705 lesions and 15 per negative. This was split into training and a 30 patient test set, balanced between positive and negative cases. We compared 2 input configurations, QSM only versus QSM plus flare, using a self-configuring 3D NNU net. The network had 6 decoding stages and was trained with 5-fold cross-validation. Here you can see the overall pipeline from MRI pre-processing and registration through to the deep learning-based segmentation that produces the predictive per masks. We evaluated performance at 2 levels. At the patient level, we measured detection sensitivity, and at the lesion level, we matched predicted lesions to ground truth using intersection over union, or IOU. we applied an IOU threshold of 0.3 for detection and segmentation metrics and a more lenient 0.1 for the FRC analysis. Our metrics included sensitivity, precision, F1 dice, Hansdorff distance, and volume difference. Statistically, we used McNemar's test for detection and the chi-square test for precision and Wilcoxon sign rank test for segmentation quality. Turning to our results, among the patients assessed, roughly 35% were PER positive. In that group, the median age was 38 years, about 72% were women, and the median disease duration was 7 years. Nearly all had a relapsing phenotype with a median EDSS of 2. Across these patients, we identified 705 lesions with a mean lesion volume about 398 cubic millimeters, distributed predominantly in the juxtacortical and periventricular regions. At the patient level, both models achieved 100% detection sensitivity, correctly identifying every PER positive patient. The key difference was specificity. The QSM-only model reached 86.7% versus 66.7% for the multimodal model. QSM-only also gave higher precision, higher overall accuracy at 93%, and a stronger F1 score. ROC analysis confirmed the superior discrimination of the QSM-only approach. This figure shows the patient-level detection performance, including the ROC curves where the QSM-only model demonstrates the stronger discriminative ability. At the lesion level, across 203 lesions, the QSM-only model detected 148 lesions compared with 126 for the multimodal model. It delivered higher sensitivity, higher precision, and a significantly higher F1 score. It also achieved a higher FRC score, 0.63 versus 0.55, indicating better detection with fewer false positives. For the lesions that were correctly matched, segmentation quality also favored the QSM-only model. It produced a significantly higher dice coefficient and intersection over union, and a lower volume difference, all statistically significant. The Hansdorff distance was slightly lower, but did not differ significantly between the two models. Here are representative examples comparing the ground truth and predicted PER masks on QSM, showing how closely the model segmentations follow the true lesion boundaries. Similar to the previous slide, this slide shows segmentation masks that were consistent across different models, and segmentation masks that were missed by the deep learning models and that were correctly detected by the deep learning models. The disease severity as measured by EDSS did not show significant differences among the patient groups with different PER burdens. However, patients with higher PER burden had significantly worse cognitive function as measured by SDMT. Finally, this figure shows our clinical correlation. Using partial Spearman correlation analysis, we related automated PER burden to the Symbol Digit Modalities Test, or SDMT, a standard measure of cognitive processing speed in MS. A higher PER burden was associated with poorer cognitive performance. So what do these findings mean? Our QSM-only deep learning model performed the multimodal approach for automated PER quantification. We see three main advances. First, an end-to-end whole brain analysis that avoids patch-based pre-processing. Second, the first demonstrated that QSM-only segmentation can reach clinically usable performance, challenging the assumption that multimodal input is required. And third, a unified framework that performs detection and segmentation together, avoiding the inconsistencies of sequential pipelines. Clinically, PER burden is linked to disability, relapse risk, and disease progression, and its dynamics can track treatment response. Our model quantifies that burden and its volumetric change, which can support therapy decisions and patient stratification in research. Importantly, increased PER burden was significantly correlated with patients' cognitive function, and by automating this assessment, the model reduces manual workload and inter-rater variability while enabling standardized quantitative MRI matrix. We should note some limitations. Our clinical associations are cross-sectional, so longitudinal outcomes such as EDSS change, relapses, or progression remain to be assessed. This was a single-center study with a modest sample size and a predominance of relapse-remitting MS, and we did not test specificity against other demyelinating conditions such as NMOSD, MOGAD, or tumor-effective demyelinating lesions. To conclude, we developed and validated a QSM-only deep learning model that enables automated PER detection and burden assessment, performing comparably to, and in several respects, better than the multimodal QSM plus FLAIR approach. It offers reliable, standardized PER quantification, and higher PER burden we measured was associated with poorer cognition, supporting its potential as a biomarker in MS. Thank you very much for your attention.